Okay, let's dive right into this explainer. Today we're looking at the invisible threats lurking inside the human body's plumbing system. We spend a massive amount of time in medicine talking about the heart as a pump, right? We monitor how fast it beats, we measure how hard it works, and we constantly evaluate its overall output. But today, we're completely shifting our focus to the pipes themselves. Specifically, we're going to look at the silent, often deadly way those pipes push back against the flow of blood. Think of it like a kinked garden hose inside your body. The water's still running, it's trying to get through, but the pressure behind that kink is silently and relentlessly building up over time. And because this is happening deep within your vascular system, there are no alarms going off. There's literally no immediate pain alerting you to the problem. It's just a steady, dangerous escalation of pressure until a critical, life-altering failure occurs. This isn't just some dramatic metaphor. This is the everyday reality for millions of people walking around with undetected pressure issues right now.
So throughout this explainer, we're going to explore exactly how this hidden systemic resistance, which the medical community officially calls vascular resistance, drives two completely different yet deeply connected medical mysteries. We'll uncover how the physical resistance that blood absolutely has to overcome to flow is forcing a massive fundamental shift in how doctors diagnose and treat both chronic liver disease and a highly stealthy form of high blood pressure.
Section 1. Decoding portal hypertension. So, for years, the absolute gold standard for diagnosing clinically significant portal hypertension was, honestly, a highly invasive and physically taxing procedure. Doctors literally had to thread a catheter through your vascular system all the way into the hepatic vein just to measure the pressure gradient across the liver. If that pressure hit above 10 millimeters of mercury, it meant you had a confirmed dangerous level of resistance, a major red flag. But as you can easily imagine, threading catheters deep into a patient's internal organs? Yeah, not exactly the ideal method for routine, everyday screening. Thankfully, clinical guidelines are finally shifting away from those invasive catheters. Instead, the medical community is leaning hard into non-invasive sound wave technology, like transient elastography or FibroScan, to measure how stiff the liver has actually become. By firing sound waves into the tissue and measuring how fast they bounce back, doctors can calculate the resistance without making a single incision. It's a massive, truly transformative leap forward for patient comfort, safety, and, well, just highly scalable screening. This brilliantly illustrates the modern diagnostic algorithm when a doctor suspects this hidden pressure. It starts super simply and elegantly with the Doppler ultrasound as the first line of defense, just to visualize the vessels and make sure the blood is actually flowing. If things are a bit unclear, the protocol steps up to CT or MRI scans to map out collateral veins. These are basically the body's emergency detour routes around a vascular blockage. And finally, the whole process culminates in precise elastography to assign a hard, actionable number to the liver's physical stiffness. But here's where doctors run into a massive real-world dilemma. Sound waves aren't absolutely perfect. When a patient's liver stiffness score falls between 15 and 25 kilopascals, they enter what hepatologists call the gray zone. It's completely indeterminate territory. Actually, up to 60% of patients with advanced but stable liver disease land right here in this gray zone. This leaves them stuck in diagnostic limbo, historically needing those invasive endoscopies or catheters anyway, just to figure out what the heck is really going on inside. So, to solve this mystery, the latest international medical guidelines introduce a fascinating twist. Look away from the liver and look at the spleen. Because the spleen sits right upstream of the liver in the circulatory system, resistance in the liver acts exactly like a dam. It causes the spleen to literally engorge and stiffen as blood backs up. By measuring spleen stiffness, doctors suddenly have a powerful tiebreaker. Values under 21 kilopascals safely rule out immediate danger, while values over 50 confirm the condition. This brilliant diagnostic pivot drastically reduces the need for those invasive endoscopies. Armed with these highly accurate non-invasive clues, the AASLD guidelines now empower doctors to go on the offensive. Instead of just waiting around for a catastrophic bleed to happen, they can proactively prescribe non-selective beta blockers, specifically carvedilol, to artificially lower the pressure. It stops severe complications before they even start. It's a total paradigm shift from reactive crisis management to proactive preventative care. Section 2. The Diastolic Hypertension Mystery. Now let's pivot away from the liver for a second to a cardiovascular condition that's incredibly common but highly overlooked in younger and middle-aged adults. Looking closely at the specific hemodynamic patterns for isolated diastolic hypertension, you can really see how unique this condition is. It's completely different from the high blood pressure older adults get, which is typically driven by stiff, aging large arteries. Instead, this specific condition is uniquely driven by high peripheral resistance. The large arteries are perfectly fine, but the tiny resistance vessels deep in your tissues clamp down tight, driving up that bottom blood pressure number while leaving the top number completely normal. The crucial point here is just how tricky this silent resistance is to definitively diagnose. Different global guidelines actually debate the exact threshold numbers. For example, US guidelines flag the danger zone at 80 to 89 millimeters of mercury for that bottom number, while European guidelines set the bar a little higher at 90. But honestly, regardless of the exact threshold, catching this narrow pulse pressure where the bottom number creeps dangerously close to the top number absolutely requires diligent out-of-office ambulatory monitoring. A single fluke reading in a doctor's office, it just isn't enough to confirm it. Section 3. The insulin resistance axis. But what is the hidden villain actually causing those tiny resistance vessels throughout the body to clamp down in the first place? Like, why does a totally healthy-looking 35-year-old suddenly have the plumbing resistance of someone twice their age? Well, this incredible diagram maps out the biological root cause: insulin resistance. When a patient becomes insulin resistant, their body pumps out excess insulin to compensate, and this excess insulin triggers a pretty devastating three-pronged attack. Neurally, it overactivates the sympathetic nervous system, keeping the body in a constant stress state. Vascularly, it directly impairs the blood vessel's ability to dilate and relax. And renally, it forces the kidneys to hoard sodium and fluid. Together, these pathways physically force the entire body into a high-resistance state. Because this specific type of high blood pressure is fundamentally a metabolic issue, doctors can't just treat it like standard hypertension with a generic pill. Instead, they can now use pragmatic, everyday blood tests to spot the underlying insulin resistance early on. Using scalable mathematical formulas like the TIG index or MEETS-IR, which simply look at standard glucose, triglycerides, and BMI numbers that you probably already have from your annual physical, doctors can correctly flag this overlooked metabolic hypertension phenotype before it causes lasting vascular damage. It's pretty amazing. Section 4, a personalized medical future. Let's bring this all together. Whether we're using sound waves to measure the resistance pushing back against a liver, or using metabolic blood panels to understand exactly why tiny arteries are clamping down and driving up diastolic blood pressure, the overarching theme of this explainer is super clear. Medicine is shifting rapidly toward a non-invasive, personalized, multidisciplinary approach. We're no longer satisfied with just treating the symptoms and numbers on a screen. We're successfully uncovering the hidden forces actually driving them. I'll leave you with this provocative thought as we wrap up. If high pressure in your liver or your arteries is really just the mechanical symptom of vascular resistance, perhaps it's time we stop looking at high pressure solely as a plumbing problem. Instead, we need to start listening very closely to what our metabolism is warning us about. Thanks so much for joining me for this explainer, and as always, keep questioning what's beneath the surface.